Hi friends, I hope all of you are doing fine. Your SM has come back with a cup of coffee again. So sit back with me for some time and let's discuss a case. Time for a case discussion. This time I am posting a case of maxillary full arch implant rehabilitation. It's FAIR. What are the things that we need to consider when we rehabilitate a full arch? Let's discuss these things now. First thing, when a patient comes to you with a full arch edentulous span, you need to see what is there in the opposite arch. Does the opposite arch contain natural teeth? Does it contain a bridge again on the natural teeth? Or is it edentulous as well? Or is there any denture that is present in the opposite arch? See that and note it down. Because when you probably finalize a prosthesis of the concerned edentulous span or the arch, you need to see the opposite arch also and then finalize which kind of prosthesis do we need to give to the concerned or the respective edentulous space that you have. So first note down what is present in the opposite arch. Second thing is, once you see into the oral cavity, look out for the prosthetic space that you have in between the arches. Now, prosthetic space is not the freeway space. Many people misunderstand prosthetic space with the freeway space. Prosthetic space is the space that is present between the implant platform and the future incisal edge of the restoration. This is the meaning of prosthetic space. So, how much of that space do you have? The best method is, suppose a patient has a denture already and the denture is not worn out completely and the vertical dimension is still maintained. You can measure the denture from the intaglio surface to the incisal edge and then note down the prosthetic space. Now let's say you don't have a denture, then what you can do, you can simply make one occlusal rim, adjust the visibility of the occlusal rim, adjust the occlusal plane of the occlusal rim, and then see the freeway space and measure the distance between the intaglio surface of the occlusal rim and the incisal surface of the wax that is present on the occlusal rim, and note it. Now this prosthetic space will decide, should I go with implant level? Can I go with MUA level? What kind of prosthesis can I give it to the patient? There is a separate classification for it, and sometime again, I will probably come back with the classification. But as of now, note down the prosthetic space that is available for a single arch. And once that is done, once you have talked to the patient about the financial aspect and the patient is okay with it, patient says let's go with it, you have to see the soft tissue that is present on the arch. Whether you have 2 mm of keratinized soft tissue or more or less. Because it's a very, very important factor when it comes to a full arch restoration. You should have good amount of keratinized soft tissue around the implants. So do I have to go with a soft tissue augmentation? Do I have to increase the soft tissue thickness there? That you take a call. Second thing is, you have to take OPG or a CBCT directly and see how much of bone is present. Do I have to do some kind of bone grafting? Leave the patient for a certain amount of time and then re-enter the bone after you get good bulk of bone? Or can I enter the bone with implants and then augment with bone grafting? Or there is no need for bone grafting, directly I place implants into the bone. So these things also you have to consider. And finally, AP spread. The spread that we give for the implants, in order to make sure that the antero-posterior spread of the restoration is from the first molar to the first molar on both the sides respectively. This is known as AP spread. And in case you don't have bone behind the sinus, then you can always use all on 4 concept or all on 5 concept or all on 6 tilted concepts, and make sure that the AP spread is till the second premolar or the first molar. If you're getting the first molar AP spread, it's the best. If you're getting the second premolar AP spread also, it's okay because it's a fixed restoration and I can afford to have 1 molar as a cantilever. So these are the few things, and then once you see the CBCT, once you assess the intraoral clinical conditions, you go and place implants. Now, coming to the case per se here. So this patient came to me with maxillary edentulous arch and mandibular fixed bridge over natural teeth. It's a full arch fixed bridge which is present over the natural teeth. I could see the bridge is exposed here and there. The periodontal condition of the bridge is not that great, but patient is not willing to get it removed as of now and go for implants. Luckily for me, the occlusal aspect of the bridge is fine. It's quite good. So I can take it as a guide to build the occlusion of the maxillary prosthesis, and later on, whenever the patient is ready for a lower implant bridge, I can remove this and place implants and give occlusion. This is also a very important point, because if your lower bridge has occlusion which is probably steep or which is zigzag or random, then you have to plan in such a way that the occlusal aspect of the opposite arch is first determined well, is corrected, and then you go for the opposite arch. This is very important, because your maxillary arch, suppose this patient has a maxillary edentulous arch, maxillary arch occlusion depends on the mandibular present teeth occlusion or the present bridge over the natural teeth occlusion. So that needs to be corrected first, and then you have to go with the maxillary bridge or a restoration with occlusion. Here, luckily, the occlusion was fine when it came to the mandibular, so it was not a concern for me. I could directly go with the implant placement and restoration. So I took CBCT. In this case, I took an OBG, and I saw that there is absolutely no bone behind the second premolar. So I had to plan all on 4 in this case, and also the bone is very, very thin in sections. The intraoral view gave me a picture that I have good amount of bone, but it was all flabby tissue above the bone. The bone is very, very thin inside. So I had to probably engage the nasopalatal area also here and go into the space and engage the bone. And on both sides, I had to take the bone into consideration, engage the bone which is present, and go with longer implants and spread the antero-posterior dimension of the implant placement well till the second premolar. So I used all on 4 tilted concept here, went with longer implants, 16 mm implants, 13 mm implants, and I got good AP spread till the second premolar area. And once I placed the implants, I placed multi-unit abutments immediately because I had good prosthetic space for the same, and I gave a denture which is a provisional denture over it, which is relined by a tissue conditioner by 4 mm. The patient came back to me after 3 months. Healing was absolutely fine, so I went ahead with my scans, digital scans. Here I used universal scan bodies which can be used on any system, and I scanned it, maxillary scan, mandibular scan, and a digital jaw relation scan as well. Now when it comes to digital jaw relation scan, you have to be very, very particular about the prosthetic space to be communicated with the lab. You either have to send a jaw relation record, you either have to send a try-in denture, or you can send the previous denture which is present. Here I had a denture which is relined already with tissue conditioner, so I sent that as a record along with the Facebook record after the scans. So what lab did? Lab has given me a PMMA try-in. I did the PMMA try-in and it was absolutely passive here. These days, for a digital fire and forget philosophy or concept with universal scan bodies, I am not using any verification jigs. I am using a PMMA directly try-in to see the passivity, to see the visibility, and to see the occlusion all together. That's the advantage of this universal scan bodies, and it's absolutely working superbly for me. It's giving great results. I've done around 36 to 37 full mouth implant rehabs only with this fire and forget concept. I'm not telling about the whole thing, only with fire and forget, and probably around 34 were bang on passive. 2 had minor defects and I could correct it. But for a beginner who is going on with the digital concept, I would advise or suggest you to go with a verification jig also. Make sure that it is passive and then go ahead with PMMA trying. For me, I'm not going ahead with a verification jig because I'm quite confident of how I'm dealing with the case, and I know that the PMMA trying that I get would be passive enough. Fine, the PMMA trying is done. I had a very small bite issue here, so I took one more record here with a jet bite, which is a bite restoration material, and I sent this across to the lab. Now lab has corrected the bite. They sent me all the pictures of the corrected bite, and I said, yeah, please go ahead and give me a bistrine. The bistrine is ready. Here the material that I've selected for the prosthesis is a cobalt chromium bar on which a zirconia superstructure is luted on. As I have ceramic on the lower arch, I could go with something known as zirconia. But if you have a denture on the lower arch, it's better you go with acrylic. If you have natural teeth on the lower arch where dentine is exposed or the enamel is shattered or broken down, then you can go with ceramic, which is softer than zirconia. In such cases, avoid zirconia. Avoid zirconia in parafunctions. Avoid zirconia in probably a patient with muscle pain or TMJ pain because it loads more. A zirconia full arch screw retain restoration is a no-no because it breaks at the connectors. Here what I've done is I've taken a cobalt chromium bar as the initial framework over which the zirconia superstructure is luted on, so it does not break at the connectors anymore here. It's a great combination. You can use that. So I've got it. I've done the bistrine. I've done the occlusal check. I've done static check, posterior, anterior. I've done dynamic check, posterior, anterior, and then I've fine-tuned to around 12 to 8 microns all over. And finally, with a shin stock, I've checked it. The occlusion is perfectly fine. I've given a mutually protected occlusal scheme with a shallow protrusive and shallow late protrusive groove function. Everything is fine. And I took a post-op OPG, few pictures, and the patient is ready to walk out. I will be giving a protective splint to the patient because it's a combination of zirconia and ceramic, and I need protection of both the arches now, not only one arch. So I'll give a protective splint to the patient to use, and after 6 months I've told the patient to get a check on the lower arch so that I can take a call, or the patient can take a call, whether the lower teeth can be removed and implants can be placed again in the lower arch. So that's how I finished this case. And important points here: implant placement, MUA placement, temporization. Then after 3 months of osseointegration, you have to go with either open tray impressions or digital scans. A jaw relation, either digitally or physically. If you're using physically, I would suggest you to go with the 2-piece jaw relation. Once that is done, do a verification either in the form of verification jig or in the form of PMMA trine. If you want both, you can do a verification jig and again ask the lab to send you a PMMA trine. The advantage of PMMA trine is you can check visibility, you can check phonetics, you can check occlusion, everything you can check, and send this across to the lab. The lab will scan the PMMA trine now because you've done the corrections, and once it is scanned, it will be transferred onto the bistrine. And once the bistrine is ready, you again check the visibility, phonetics and occlusion, send it across, they will glaze or polish and send it back, and you will get a beautiful functional, aesthetic and phonetic prosthesis in the form of full arch implant rehabilitation. Don't forget to give a protective splint if at all you feel that the prosthesis and the implants need to be protected. Do a recall of the patient 48 hours, do a recall of the patient 6 months, and after that annual. Keep the patient on maintenance. Maintenance is very, very important. Tell the patient to buy a water flosser and water floss the prosthesis underneath every night before the patient sleeps. I hope this presentation helps you in a little way. I'll be back again very soon with one more interesting case in the Coffee with SM series. Cheers, guys.